Hello, my name is Dr. Calynn Lawrence, and I am the founder of the Holistic Healing Source for Marginalized Society. I am a board certified forensic traumatologist, a trauma specialist, and a pastoral counselor by trade. Let's go ahead and get into this presentation. Let me go ahead and share my screen. Creating a whole person ecosystem of care. Building cross disciplinary partnerships and referral systems within your service community. The modern health and wellness landscape is undergoing a necessary evolution from fragmented, siloed treatment models to comprehensive frameworks that address the physical, psychological, social, and spiritual dimensions of an individual's well being. This transition toward whole person care cannot be achieved by a single practitioner or even a single organization. It requires the deliberate construction of a care ecosystem, a robust network of cross disciplinary partnerships and referral systems that spans the macro systems level down to the micro individual practitioner level. By integrating community organizations, social services, primary care, and specialized disciplines, health systems can address the foundational determinants of health while delivering deeply personalized care. Building this ecosystem demands structural investment, intentional co design, and the dismantling of traditional professional hierarchies. The macro level, upstream partnerships and community wealth building. To truly support whole person health, systems level collaboration must address the upstream causes of poor health outcomes. Healthcare based interventions addressing social needs such as food and housing generally fail to impact the upstream wealth and power inequities underlying those needs. However, a small number of healthcare organizations have begun addressing these upstream inequities by partnering with community wealth building initiatives. These macro level partnerships require healthcare organizations to step outside traditional clinical boundaries and invest directly in the communities they serve. These initiatives include community land trusts, resident owned communities, and worker cooperatives, which provide local residents ownership and control over their housing and workplaces. Partnerships are generally motivated by a combination of community needs, such as affordable housing and living wage jobs, and health system interests, such as workforce housing and supply chain resilience. Living wage jobs and health system interests, such as workforce housing and supply chain resilience. Initiating these projects requires identifying external partners, educating leadership, and utilizing risk mitigation strategies to obtain health system buy in. Implementation takes various forms, with healthcare organizations providing financial capital in the form of grants and loans. Healthcare organizations also provide social capital in the form of convening funders and other stakeholders. Furthermore, they offer capacity building support in the form of strategic planning or technical assistance resources. Traditional healthcare evaluation metrics, which often focus on immediate return on investment or ROI, or specific patient outcomes, are ill suited for these broad community partnerships. To evaluate projects, healthcare organizations use more process and community level metrics rather than metrics based on individual health outcomes or returns on investments. Assessing healthcare partnerships with community wealth building organizations yield key strategies healthcare organizations can use to develop more effective partnerships to address the upstream causes of poor health. The meso-level, co-designing collaborative community services. Bridging the gap between macro-level community investments and individual patient care requires strong collaboration between diverse sectors. Developing this middle tier of the care ecosystem relies on forming structured networks between social services, primary health care, and the third sector, nonprofit and voluntary organizations. Furthermore, building patient partnership in healthcare service design and delivery is an essential component of this process. To effectively integrate these disparate entities, organizations are increasingly turning to co-design processes. Co-design brings together diverse stakeholders to map current situations and jointly develop shared goals and terms of collaboration. Research evaluating these co-design processes highlights several interconnected configurations that determine their success. A key configuration concerns stakeholders' assessment of the potential value of participating in co-design process and their decision to engage. Another configuration highlights how emerging trust enables respectful and constructive dialogue. A third configuration focuses on the facilitation of ideation and prototyping of goals and terms for collaboration. Key mechanisms that drive these configurations include sensing an opportunity for change, building trust, and experiencing group agency. Establishing trust among a diverse group of community stakeholders is highly dependent on how the collaboration is managed. Successful co-design requires facilitation that not only considers contextual factors, but is also perceived as impartial, as such neutrality is vital for establishing trust. Furthermore, the characteristics of the individuals representing their respective organizations dictate the viability of the partnership. Constructive participation depends on representatives who combine relevant practical knowledge, a sense of opportunity for change, and the mandate or organizational conditions to act on outcomes. Continuity in participation, ensuring that the same individuals remain involved throughout the process, is also crucial for maintaining competence. This continuity is vital for building the relationships and trust needed to develop shared goals and collaborative structures. The micro level, interprofessional collaborative practice. At the individual practitioner level, the ecosystem of care is actualized through interprofessional collaborative practice. Interprofessional collaborative practice involves interdependence, shared responsibility and goals, newly created professional activities, flexibility to navigate professional roles, power and relationships, and attending to the collaborative process among health professionals from diverse disciplines. The integration of spiritual care specialists, such as healthcare chaplains, serves as a prime example of how distinct disciplines must navigate collaboration to provide whole person care. In an interprofessional spiritual care model, all team members possess spiritual care generalist skills and responsibilities to attend to patient spirituality within their respective scopes of practice while closely collaborating with spiritual care specialists. For this collaboration to be successful, specialists must assume dynamic roles within the care team. Research identifies 6 collaborative roles for chaplains: relationship and communication facilitation, consultation for whole person care, education, staff support, research collaboration, and collaborative leadership. Within the scope of collaborative leadership, specialists must proactively guide the team. This category includes leading by spiritual care expertise, fostering interprofessional collaboration, mediation and conflict management, advocacy and change leadership, and improved decision making. Chaplains integrate and center an understanding of diverse human values and beliefs in medical, ethical, and organizational decision making. However, individual practitioners face substantial barriers when attempting to build these cross-disciplinary relationships. The factors influencing collaboration are multifaceted and deeply embedded in the work environment. Key factors influencing collaboration include relational factors, the professional chaplain role, attitudes influencing collaboration, and leadership action. These factors are embedded in contextual factors, specifically power dynamics and organizational conditions. Power differentials and hierarchy within healthcare systems can act as barriers to shared leadership and collaboration. Organizational and contextual factors significantly influence chaplains' positioning, resources, and environments for collaboration, leadership, and integration within interprofessional healthcare teams, acting as either facilitators or obstacles. For interprofessional collaboration to thrive, practitioners must have professional role clarity, mutual understanding, and respect. Conversely, a lack of role clarity, unfamiliarity, and misunderstandings create profound barriers to collaboration. Organizations must deliberately foster an environment where interprofessional education and shared experiences are prioritized to overcome these hurdles. Overcoming fragmentation in telehealth environments. The micro level collaborative environment has been further complicated by the rapid adoption of digital care delivery. Due to the increase in demand for primary care systems, the implementation of telehealth has accelerated. However, its rapid implementation often lacked adequate infrastructure and patient and provider support. While interprofessional collaboration has long been a part of healthcare practices, the growing integration of telehealth unfolds within a professional culture that is increasingly receptive to collaborative approaches. For patients living with complex needs, such as chronic diseases, telehealth presents a dual edged reality when it comes to whole person care. Patients recognized facilitators regarding the use of telehealth, such as improved accessibility and timely contact with care teams. However, although telehealth has improved access to care, patients identified key barriers such as unclear provider roles, limited communication between professionals, and fragmented informational continuity. Strengthening interprofessional collaboration processes and addressing patient identified barriers are crucial steps toward delivering more coordinated, equitable, and effective care for individuals living with chronic disease in a telehealth context. When informational continuity is fragmented and provider roles are unclear, the referral systems that connect patients to different disciplines break down. It is imperative that healthcare organizations intentionally design their telehealth platforms to support rather than hinder interprofessional communication and cross-disciplinary referrals. In conclusion, creating a whole person system of care is a multifaceted endeavor that requires synchronized efforts across all levels of the healthcare continuum. At the macro level, organizations must invest financial and social capital into community wealth building initiatives to address the systemic inequities that dictate health outcomes. At the meso-level, social services, primary care, and the third sector must engage in carefully facilitated and partial co-design processes to build trust, define shared goals, and establish local collaborative structures. At the micro level, individual practitioners must transcend professional hierarchies and unclear role boundaries to engage in true interprofessional collaborative practice. Whether delivering care in person or navigating the fragmented continuity of telehealth, the ultimate goal remains the same: a cohesive, integrative network where patient partnerships and cross-disciplinary expertise converge. By building resilient referral systems and prioritizing relational collaboration, health and wellness communities can deliver truly transformative whole person care. And here are the references for further reading. Thank you.